Hello, good evening to one and all. I'm Harita Rajakrishnan from FCPI. It's my immense pleasure to welcome you all to the brand new forum, which is dedicated to educating the next generation of clinical pharmacists in the specialized field of solid organ transplantation. So throughout the series, we'll be discussing about the critical role a clinical pharmacist can play in the management of transplant patients. So from understanding the basics of organ anatomy to the intricacies of transplantation surgery, the importance of modulation of immunosuppressants, drug-drug interactions, patient counseling, we'll cover it all. So whether you're just starting the journey or you're looking to deepen your knowledge, the forum will definitely give you valuable insights into to help you excel in the arena of clinical pharmacist in this field. So stay tuned and let's dive into the world of solid organ transplantation together. So it's my privilege to welcome the speaker for the very first session of the forum, which is liver anatomy physiology. And we have Dr. Matthews James, sir. So a quick introduction before we move into the presentation. So sir is working as a consultant in multi-organ transplant unit of Rajagiri Hospital, Alua. He has over 12 years of experience in the field of gastrosurgery. He pursued MBBS degree at Jawaharlal Institute of Postgraduate Medical Education and Research, JIPMER, Puducherry. He did his Master of Surgery in General Surgery at the same premier institute, and he was awarded the B. N. Balakrishna Rao Gold Medal in General Surgery. He qualified for MCH training in surgical gastroenterology at JIPMER, where he assisted in the cadaveric liver transplant program. He has extensive training in open, laparoscopic, and robotic approaches in dealing with the common GI disorders. Sir has also published numerous articles in reputed national and international journals and has presented papers in national and international conferences. So thank you so much, sir, for joining the today's session. And now the session is yours.
Okay. Thank you, Harida. Thank you for the warm welcome. So today I'll be dealing with the liver anatomy, function, as well as portal circulation. So I thought I will begin from the embryology side. As and when embryo is formed, the formation of liver. The embryo, it has three layers: the ectoderm, the endoderm, as well as the mesoderm. So the liver arises from the endoderm as well as the mesoderm components. The endoderm is a part of the embryo, the three germinal layers, which gives rise to the gastrointestinal lumen. So the area from the mouth to the anal canal is formed out of endoderm. So it is broadly divided into foregut, midgut, and hindgut based on the blood supply. So the liver arises from the foregut part around the area of duodenum. And it arises from the hepatoblast, which gives rise to the hepatocytes as well as the cholangiocytes or the biliary epithelium. So the liver arises as a hepatic diverticulum that arises from the second part of the duodenum. And from here, this bud, it has two components. The one cranial bud will be there as well as a caudal bud will be there. So the cranial bud, which is called as a liver bud, it gives rise to the liver. And the caudal bud, which is called as a pars cystica, gives rise to the gallbladder as well as a part of pancreas as well. So as you can see in this image, in the initial phase of embryogenesis, the GI tract, which is aligned longitudinally along the notochord, it has a dorsal as well as a ventral mesentery. So this ventral mesentery side is where the liver arises. So as soon as the liver bud is formed, it invades into the septum transversum. That is a part which is similar to that of diaphragm, which is dividing the abdominal cavity from the thoracic cavity. So this liver bud infiltrates into the septum transversum, and the liver cells, the liver formation happens in the septum transversum. So the hepatocytes are arising from the liver bud, but the other supporting parenchyma, supporting tissue structures arise from the septum transversum. And the later phase, as the liver develops along with the embryo, the rotation of the structures occur. So that is why this liver, which is initially in the midline, it comes to the right side of the abdominal cavity, and the stomach and pancreas, which goes to the left side of the stomach. So the endoderm gives rise to the hepatoblast from hepatic diverticulum. It has two parts, the pars cystica and the pars hepatica. The pars hepatica is what which later develops into the liver proper. So it gives rise to the hepatocytes, hepatic sinusoidal cells, Kupffer cells, as well as a hematopoietic tissue, which is active in the fetal period, as well as the intrahepatic biliary tree. Whereas the pars cystica gives rise to the gallbladder and extrahepatic bile duct. And this hepatic diverticulum infiltrates the cardiogenic mesoderm, which is the septum transversum. And this gives rise to the ventral mesentery and the visceral peritoneum that is covering the liver. So the mesoderm of the septum transversum infiltrates into the is infiltrated by the growing pars hepatica, which becomes a falciform ligament anteriorly and the lesser omentum posteriorly, as we had seen in the previous images. The mesoderm on the surface of the liver transforms into the capsule and the peritoneal covering, which is also called as a Glissen's capsule. Now, coming to the portal vein embryology, portal vein is basically the venous system that deals with the nutrition. So, from the embryogenesis, during the initial phases of the embryogenesis, the nutrition comes from the yolk sac, as seen in this picture. Later on, it is from the placenta, as seen here. And finally, after the baby is born, the nutrition is derived from the GI tract. So the portal vein basically transforms through all these three phases to develop. So initial phase, the extra-embryonic venous system, that is the umbilical vein as well as the vitelline vein. The vitelline vein is the venous system that drains the blood into the heart from the yolk sac, and the umbilical vein it is driving the nutrition from the mother through the umbilical vein into the heart of the baby. So the vitelline vein, it forms a plexus around the duodenum and it passes through the septum transversum, into which this liver cord from the hepatic diverticulum grows into. So this growing hepatic diverticulum interrupts this network of vitelline venous plexus, which later transforms into the hepatic sinusoids in the adult liver. And during the phases of growth, there is a left to right shunting between the vitelline veins, where the majority of the nutrition is coming from the right vitelline vein. So this leads right to the enlarged right side of the right lobe of the liver, as we see in the adults. And the right hepatocardiac channel, which is enlarged by the shunting, which forms into the suprahepatic inferior vena cava. The anastomotic network of the vitelline veins around the duodenum forms the portal vein, and the superior segments of the vitelline veins form the hepatic veins. The proximal parts of the umbilical vein disappear, and the remaining left vein carries the placental blood via the liver into the heart, bypassing the sinusoidal plexus. So, as you can see, during the initial phase, when the yolk sac is giving nutrition to the fetus, the vitelline veins are the predominant source of nutrition. So as the fetus develops, the liver also grows in size, and this vitelline vein is divided into the sinusoids. Later, towards the term, when the baby is about to be born, the umbilical by that time the umbilical vein from the placenta has taken over the function of the vitelline veins. So the nutrition is predominantly coming from the umbilical vein, and the right side umbilical vein is uh, the right side of the umbilical vein, it will disappear as the baby grows, and the left side umbilical vein is the predominant one. So this can be seen in the adult also, because the left side umbilical vein, which later transforms into the uh, ligamentum teres, or the round ligament. This is a remnant of the left umbilical vein, and it has a clinical significance in that the patients who develop cirrhosis later, there is a recanalization of this left umbilical vein, which can be seen as a collateral channel, which is connecting with the umbilical vein. And this ductus venosus, which is diverting this umbilical vein directly to the heart without passing through the liver tissue during the fetal period. It also obliterates later on to forms the Arandius ligament or the ductus venosus, the ligamentum venosa. So coming to the topography of the liver, you can see that the liver is located in the right side of the abdomen and the upper abdomen. So it is located in the right hypochondrial part of epigastrium, as well as the uppermost portion of the left hypochondrium. This liver is entirely being protected by the rib cage as well as the anterior abdominal wall. The weight of the liver ranges from 1.4 to 1.8 kilogram in the Western population, whereas average weight seen in Indian population is around 1.2 to 1.6 kilogram. And in females, it weighs around 1.2 to 1.4 kilogram. As proportion to the body weight, it is 1 by 18th of the body weight of a newborn, whereas in an adult, it is 1 by 40th. Coming to the liver surfaces, there are two surfaces that can be appreciated on a liver. The diaphragmatic surface, that is the surface we see. We usually don't see this part once you go inside the abdomen because it is covered by the rib cage as well as the anterior abdominal wall. So this is a dome-shaped surface, with the bare area. That is the part of the liver which is not covered by the Glissen's capsule. This bare area anteriorly can be seen in the falciform ligament, which widens to engage the IVC. The inferior surface, it is a concave surface with the gallbladder, the porta hepatis, the fissure for ligamentum teres, these areas which are devoid of peritoneum. So this impressions, what you can see here is this is a left lobe, left lateral section. The impression, what you can see here is the impression of the esophagus as well as the stomach. Whereas here, with the depression, what you see is that of the right kidney. So coming to the ligaments of liver, there are false ligaments and as well as the true ligaments. The true ligaments are the remnant fetal structures, as I told before, the ligamentum teres, which is the remnant of the uh, left umbilical vein, as well as the ligamentum venosum, which is a obliterated ductus venosus, which used to divert the umbilical venous blood to the heart, bypassing the liver. Since this bypass is no more required in adult life, they become obliterated. So the ligamentum venosum is arising from the ductus venosus, and the ligamentum teres from the umbilical vein. So these are true cord structures or true ligaments, whereas the false ligaments are basically the peritoneal folds. These peritoneal folds are arising from the septum transversum. It is basically like the liver has grown into the septum transversum, and the whatever remnant of the septum transversum which is attached forms the ligaments. So the falciform ligament, which is seen anteriorly, the coronary ligaments, which are towards the posterior surface, which you can see, the triangular ligaments, where both the coronary ligaments fuse together, and the lesser omentum. The lesser omentum is the name given to the combined hepatogastric ligament as well as the hepatoduodenal ligament. Coming to the fissures that you can appreciate on the liver surface, these fissures are more prominent on the posterior surface. There are two vertical fissures which are connected in the middle by a transversely oriented porta hepatis in the shape of an H. So the left side fissure is formed superiorly by the ligamentum venosum and by the ligamentum teres inferiorly. The right side fissure is formed by the groove of IVC as well as the gallbladder. The porta hepatis, or the door into the liver, is seen in the inferior surface, which is a transverse portion of the H that was mentioned before. So this is the entry point of all the vascular structures into the liver. So the bilateral hepatic ducts, the hepatic arteries, and the portal veins enter into the liver through the porta hepatis. Along with this, you can see the lymphatics as well as the autonomic nervous fibers also pass into the liver through this. So these are portal structures which come up through the free edge of the hepatoduodenal ligament, which is forming the anterior wall of the foramen of Winslow, which has more importance surgically. So the compression of these structures through this foramen of Winslow, by applying fingers across it, is called the Pringle maneuver. This is to control the bleeding during hepatic surgeries, because at the entire the vascular inflow is coming through these three structures. And the relationship with the other organs. The diaphragmatic surface, it fits snugly into the undersurface of the diaphragm, and it is located behind the anterior abdominal wall, as we can see here. The visceral surface, as I mentioned before, the left lateral section, which is lying over the distal part of the esophagus and the proximal stomach. The right lobe will be overlying the kidney, which is located around here, as well as the adrenal gland, which is located superior to the kidney. The colon flexure, as well as the duodenum, also will be located in this. The imprints of this can be appreciated on the inferior surface of the liver. Coming to the lobes of the liver, the anatomical lobes, which are of less clinical significance because the liver is not divided basically just like that. This is the gross morphological division what we can appreciate. So this is the falciform ligament which is running through the anterior surface. So it divides into basically the left lobe as well as and the right lobe. On the visceral surface, what we can see is the right lobe, which is seen to the right side of the IVC and the gallbladder. The caudate lobe, which is seen between the ligamentum, the arrandius ligament or the ligamentum venosum and the IVC, as well as the quadrate lobe, which is located between the gallbladder, the round ligament, as well as the porta hepatis. The remaining part is the left lobe or left lateral section. So this is the classical division of the liver into segments. So there have been multiple attempts since time immemorial to classify the liver segments. Multiple attempts were made throughout the history, but the most appreciated one is that of a Couinard's classification. So this division is based on the division of the hepatic artery, the bile duct, and the portal vein. That is basically the vascular supply as well as the biliary drainage of the liver. So the right and left liver are divided by a plane which is passing through the gallbladder to the IVC. So the plane connecting this is the uh, median fissure. So this divides the liver into left and right, and not the falciform ligament as we saw before. So this line is also called as the Canley's line. That line will be approximately around this region from the IVC, which is located here, to the gallbladder. So as you can see, it is located lateral to the falciform ligament, unlike what we see in the gross anatomy. So the right and left is divided by this Canley's line. This line is the plane through which the middle hepatic vein runs. The other divisions, further division of the right and left lobe is based on the other two remaining hepatic veins. The right hepatic vein, which divides the right liver into the right anterior section and the right posterior section. The left hepatic vein divides the liver into the left lateral section, which is the segment 2 and 3, and the left medial segment, which is the segment 4A and 4B. So as you can see, the caudate lobe or the segment 1 is part of neither the right liver or the left liver. The all three division planes or the portals are called portal caesurae. And these portal caesurae are basically the planes through which the hepatic veins run, as I mentioned before. And like I told you initially, there have been multiple classification systems like a Healy and Schroy. But the most approved one, which are used by most of the surgeons, are that of a Kuno's classification. So these three vertical planes, which through which the hepatic veins run, they divide the liver into four parts vertically. And the horizontal division is through the plane where the portal vein divides into right and left. So as you can see, this is the left hepatic vein, this is the middle hepatic vein, and this is the right hepatic vein. So this middle hepatic vein divides the liver into the left lobe and the right lobe, or the right hemiliver and the left hemiliver, which will be more appropriate name. And this left hepatic vein divides into the left lateral section and the left medial section. And the right hepatic vein divides the right lobe into the right anterior section and the right posterior section. So this left lateral section is this combination of segment 2 and 3, as you can see before. So this falciform ligament is basically seen in this part over the between the segment 4 and segment 2 plus 3. So if you want to remember the order of the lobes of the river, the caudate lobe, which is not seen from the anterior view, is the segment 1, segment 2 and 3, then the segment 4, the segment 5, 6, 7, and 8. So basically it is in the clockwise direction the lobes are named. So the importance of this division is to identify the location of any lesion or for the intercommunication between the radiologists as well as the surgeons. So in imaging as well, like CT or MRI, what we could see is the hepatic veins. So this is the middle hepatic vein, this is the left hepatic vein, and this is the right hepatic vein. All three will be draining into the IVG. So this is the superior part of the liver. And as you come down the axial sections further lower, you will be able to see the portal vein division. So here what you are seeing, this is the middle hepatic vein as an indone view. This is the right hepatic vein, and here will be the left hepatic vein. This is the portal vein which is coming from inferior, which is dividing into the left portal vein as well as the right portal vein. So basically, based on these anatomical landmarks, which is very well appreciated in the triple phase CT, you can divide the liver into the multiple lobes and you can identify or pinpoint where the lesion is. So as you can see in this image, this is a segment 2, this is a caudate lobe or the segment 1, this is 4A, which is a superior. These are the superior segments, 2, 4A, 8 and 7. These are located above the plane of the portal division. So as you come down, you can see here, this is a right portal vein. So this is the plane of the division of the portal vein. The left side is not seen here because it's a little bit higher. You have gone beyond that in the axial section. So at this level, what you see will be segment 5, segment 6, and segment 4B. So here we can confidently tell that this lesion is located in segment 8 because it is between the MHV and the RHV. So here will be the segment 2, here will be segment 4A, here will be segment 8, and here will be the segment 7. So it is easy to communicate where the lesion is, and the surgical division, the planning, all are based on this. So from a surgeon's view, you can appreciate that the right hepatectomy will be the entire removal of the right side of the part of the liver that is to the right of the middle hepatic vein, which includes the segment 5, 6, 7, and 8. And the extended right hepatectomy is when we remove one more section in addition to the right liver. So here it is the segment 4. Similarly, the left hepatectomy is the removal of the entire liver that is to the left side of the middle hepatic vein, that is segment 2, 3, and 4. And for the extended left hepatectomy, you have to remove segment 5 and 8. For example, this lesion, this tumor, which is located in uh, the middle of the liver. So it basically involves a segment 4, segment 5, and segment 8. So to completely clear this tumor, we'll have to remove the mid portion of the liver. Herein, we can preserve the left hepatic vein, which is draining the segment 2 and 3, and the right hepatic vein, which is draining the segment 7 and segment 6. Coming to the blood supply of the liver is a highly vascular organ, and this leads to the difficulty in operating on, unlike any other organ. So it has a dual blood supply, which is from the hepatic artery as well as a portal vein. So you might be confused that the blood supply is coming from artery as well as a vein, because normally what we know is that an artery is a organ which is giving the blood to an organ, and the vein is the part which is taking the blood away from the organ towards the heart. But here is the importance of the portal vein, which we'll come to later. The hepatic artery supplies only 25% of the blood to the liver. But since it is an arterial blood, it supplies 50% of the oxygen requirement. Whereas the portal vein, it supplies only 75% of the blood, and it is giving rise to the 50% of the oxygen requirement because it is a venous blood, which is coming back from the bowel. The only difference being that artery is the only thing that is exclusively supplying the biliary tree. The rest of the entire liver will be supplied both by the artery as well as a portal vein. So this is why in surgeries, when there is an arterial injury, even though it won't be apparent immediately because the liver function is not compromised, but later on, since the artery is compromised, the biliary tree will be compromised, which will not come immediately later on uh, as the time progresses. So once the biliary tree is compromised, there might be stricture and the patient might develop complications, biliary complications. So the artery commonly arises from the celiac axis, but occasionally a replaced hepatic artery can arise from the superior mesenteric artery or rarely from the aorta directly. The portal vein is formed by the combination of the splenic vein as well as the superior mesenteric vein. The artery, the portal vein, along with the bile duct, is invested in a fibrous sheath which is called the Glisonian pedicle. The same the sheath that is covering the capsule that is covering the entire liver. Hence these three structures are whenever you are seeing in the anatomy, it will be all together: the hepatic artery, the portal vein, and the bile duct. As we progress further into the liver, the small arterioles, the venules, and the biliary ductules, all will be seen going similarly with invested within a sheath. Hence, these are called the portal triad. This sheath covering is absent in the hepatic veins. Coming to the venous drainage, there are three major hepatic veins. The right hepatic vein, middle hepatic vein, and left hepatic vein, as we have seen previously. So this is the basis of the division or the division of the liver into the segments. So these hepatic veins, they lack glycogen pedicle. So it is easy to injure them and can lead to tremendous bleed, which is difficult to manage because whenever you are taking a suture to control the bleed, it can tear through it. Whereas the glycogen pedicle in the artery and the portal vein, which gives an additional security whenever we are taking a suture. The middle and left hepatic veins usually join together to form a single trunk within the liver itself just before joining the IVC. All the three veins drain directly into the inferior vena cava. In addition to these three veins, there might be inferior hepatic veins. These are small veins which are draining the parts of the right liver into commonly the segment 6 and 7. And occasionally the size will be significantly larger when the major hepatic vein size is smaller. So in such conditions, whenever we are doing a surgery like a liver transplant, you are bound to anastomose this inferior hepatic vein as well into the IVC. And these hepatic veins drain the entire liver except the caudate segment because the caudate drains directly into the inferior vena cava by multiple small veins. Coming to the nerve supply of the liver, the liver has sympathetic supply which forms a rich plexus around the vessels as well as the bile duct as well. And they run along into the sinusoidal walls to supply the liver lobules. It also has a parasympathetic fibers which innervate the hepatic artery, the portal vein, and the hepatic vein also. And this sympathetic or the autonomic system thereby controls the blood flow and metabolism. But the significance of this have been in question with the advent of liver transplant. Because during a transplant surgery, we are anastomosing only the vessels as well as the bile duct. There is the anastomosis of the lymphatics or the nerves are out of question, but still the liver functions adequately. So whether this really control this metabolism and the blood flow is a matter of question. Now coming to the microanatomy, the liver cells, the hepatocytes are polygonal cells which are arranged in 1 to 2 cell thickness sheets which are separated by sinusoids. So there's terminal arterioles and the portal venules, like you can see here. This is the terminal arteriole, and this is the portal venule. And the green structure, what you can see is the biliary duct. So these three structures, this supplies the sinusoids. So the blood has reached into the sinusoids, the arterial as well as the venous blood will mix together, and from there it drains into the hepatic vein. This is the central vein which eventually drains into the hepatic vein. So this sinusoidal cells, which is tracking in between the central hepatic vein and the portal vein, the portal triad. These are unlike the endothelial cells that you see in the any vein or an artery. These endosinusoidal cells do not have a basement membrane, and these cells have multiple fenestrae, which forms a leaky barrier. So the plasma is able to diffuse from the sinusoidal space into the outside the sinusoidal space. So this perisinusoidal space is called the space of disease, and it contains the plasma as well as collagen as well as cells called the stellate cells, which will come into later. So the plasma which accumulates into the the space of disease, it eventually drains into the space of Marl, which will come to in the next image. So this is a cross-sectional image where you can see the portal triad, that is the portal vein, the hepatic artery, and the bile duct. So this portal triad in the artery and the vein, which combinedly drain into the hepatic sinusoid. The sinusoids are lined by the sinusoidal endothelial cells. So these cells, they have multiple fenestrae. So through this fenestrae or the openings, the RBCs or the major proteins are unable to go across, but the plasma and the smaller proteins, including albumin, is able to go across this. So here it is lined, this space is lined by the hepatocytes. So the diffusion of uh, both the nutrients as well as metabolites occurs from the blood into the hepatocytes in the space of this. So once that happens, the remaining blood, the plasma and the lymph, they drain into this space. This space is the space of Marl where it drains into the lymphatics and it goes back into the lymphatic veins. So here you can see the artery, the portal venule, both giving their blood into the liver sinusoids, and the sinusoids drain into the central venule. So this is a microscopic image. Here the hepatocytes, and these are the fenestrae which you can see in the endothelial cells. So this endothelial cells, usually in any artery or vein, there will be basement membrane on which the endothelial cells lie. So due to the absence of this basement membrane and the presence of multiple fenestrae, the blood, the plasma freely diffuse across into the space of disease. So this bile canaliculi, which is located in the canalicular membrane, that is the opposing surfaces of the hepatocytes, there are small space. Here, the hepatocyte secretes the bile into. So these combine together and they drain into slightly larger canals, which are formed by, again, lined by both the hepatocytes as well as the cholangiocytes starts to appear there. They are called the canals of Henry, which in turn drain into the bile ductules, then form the hepatic ducts and the common bile duct. So the organization of hepatocytes as well as the sinusoidal cells and the endothelium, the biliary epithelium, it's a architectural wonder, because the liver is organized in such a way that the entire blood from the hepatic vein, the portal vein, as well as the hepatic artery, drain in a specific way, and it reaches the central venule to be drained into the hepatic vein. So this is called a hepatic lobule, the classic hepatic lobule, which is ideally drawn as a hexagonal structure with the portal triad located in each angle. So these are the sinusoidal spaces in between which are located the hepatocytes. So the blood from the portal triad comes through this sinusoidal space and drain into the central vein. So this classic hepatic lobule, it's a hexagon with a central vein, which is called the hepatic venule at the center, and the portal triad at the three corners. For a pictorial representation, we have made it as showing at the six corners, but it's usually seen in three corners. Then the another concept is that of portal lobule, because liver is considered as a gland, and like any gland, the cells will be arranged in such a way that the glands secrete their products into the duct. Here the duct is a bile duct. So the bile duct, which is located in the portal triad, it is located here, and the triangular structure which is connecting all the three hepatic venules, central venules. So this is called as a portal lobule. And another concept is that of a liver acinas, where the diamond-shaped parenchyma, which is supplied by the afferent vessel, both the artery and portal vein, with a central vein at the periphery, which drains into the such acini. So this is basically this diamond-shaped liver acinas. These are all basically concepts to explain the structure as well as the function of the liver, the architecture, how the blood flows, and how the bile forms, and how the metabolism happens. So this liver acinas is also explained in such a way that it represents a structural as well as a functional unit that it can explain lesions like bridging necrosis and fibrosis, which is commonly seen in liver cirrhosis. So this liver acinas has three zones. The periportal zone, which is immediately around the portal triad, which has a high oxygen containing blood because the blood is just starting to flow from there. And the perivenular zone, which is the zone near the central vein, and which has a blood with the least oxygen concentration, and an intermediate zone where the oxygen concentration is lesser than the zone 1 but greater than the zone 3. The importance of this lies in that the liver has arranged its cells in such a way that the metabolism happens. The important metabolism which requires a higher oxygen concentration occurs in the zone 1, whereas those which require minimal oxygen concentration occurs in the zone 3. So the oxygen gradient across the lobule leads to differential expression of the genes for metabolic pathways. So this is basically metabolic zonation. So the periportal zone or the zone 1, which has a high oxygen concentration and high nutrient concentration, the gluconeogenesis occurs, the liver cell regeneration occurs, and bile duct proliferation occurs. Whereas the perivenular zone, where with the lowest oxygen concentration, the detoxification occurs, the glycolysis and the hydrolysis occurs. So this is the pictorial representation of the three or anatomical the organizational architecture. These are basically concepts. So the classical lobule, which is hexagon shaped, and the portal lobule with the bile duct in the center, and the liver acini, where the function is better explained. Now, coming to the portal circulation, a portal system is basically defined as a circulatory system which begins as well as ends with capillaries. So here in the portal circulation, the portal vein begins from the capillaries which drains into the venules from the bowel, the small bowel as well as the large bowel, the stomach, pancreas. So the blood from all these capillaries which drain into the venules come into the portal vein. Then in any other organ, all this blood would have gone directly into the heart. But here, this is a portal system. So it again splits into capillaries. Like we saw in the previous image, these small arteries and the portal venules, which again form the sinusoids. Then from the sinusoids, it goes into the hepatic vein, and from there only it goes into the heart. So this portal system, it drains the entire GI tract from the stomach till the mid-rectum, where the entire the digestion and the assimilation occurs. So in the liver portal system, the capillaries of the intestinal and splenic mesentery ends in the hepatic sinusoids, delivering the nutrient-rich blood for processing them for utilization or storage. It also removes the toxic substances from the blood before it reaches the systemic circulation. So the pathology which can arise from this is that of portal hypertension. It is the elevation of a portal blood pressure more than 5 millimeter of mercury. The portal hypertension is a condition which is commonly seen in conditions of a cirrhosis. This develops due to chronic liver injury or the cirrhosis, which activate the stellate cells which are located in the perisinusoidal space, in the space of this. So this is the stellate cell, which are the fat storing cells or the cells which store vitamin A. So due to chronic irritant exposure like alcohol or in cases with a fatty liver, these stellate cells become activated and they become myofibroblasts. So once they become myofibroblasts, they start secreting the uh, materials like hyaluronic acid, collagen, and it indirectly results in the formation of a basement membrane. So once the basement membrane forms, this leaky surface of the sinusoids disappear, and it becomes like a similar to that of a capillary. So it's basically called the capillarization of the sinusoids. So the once leaky surface, the sinusoids become rigid structure like a capillary. So there is no further leak of plasma that is happening into the perisinusoidal space, or it has reduced significantly. So this leads to increase in the pressure within the sinusoids, which is reflected in portal hypertension. So the chronic liver injury, it activates the stellate cells in the perisinusoidal space and secretes collagen and forms a basement membrane, leading to the capillarization of the sinusoids. So there is no further leaky fenestrae, or the amount of leakage through the spaces decreases, resulting in increasing the pressure inside the sinusoids. This results in portal hypertension. So the clinical impact of portal hypertension is that the venous flow into the liver will become limited, because there is no structure like a heart to pump this blood. It is a passive flow from the small bowel and the colon into the liver. So whenever there is an increase in pressure, or the body has to fight across this increased pressure within the liver, it forms or finds an alternative pathway which is of low pressure. So that is the significance of portal hypertension, and it occurs due to increased portal resistance as well as the increased portal flow. Because once the liver becomes cirrhotic, there are a lot of biochemical factors happening, like increased production of nitric oxide, which leads to the vasodilatation in the splanchnic bed. So the entire vessels within the GI tract becomes dilated, and a lot of blood starts pooling in this part. So this leads to increased blood flow or the hyperdynamic circulation, that combined with the hypertension within the liver. So this leads to the portal hypertension, and the portal blood flow finds an alternative pathway to drain the blood into the heart. So these pathways are arising from the normal pathways which exist in every human, but these are very minimal or more, almost kind of obliterated, because there is no need for the blood to go through this pathway. Because there is an obstruction and there is a high pressure, these pathways again open. So as you can see, the the obliterated umbilical vein, which is connected to the umbilicus, which reopens. So once it reopens, the umbilical vein, the veins drain, the fetal veins which were draining into the abdominal wall, which also becomes dilated. So this becomes like a spider web-like pattern, which is also called as a caput medusae, because due to its resemblance to that of a head of Medusa. And the other points of the photosystemic collateral formation is the G junction. So here the left gastric vein, which drains into the portal vein directly, which which connects with the small venules and into the esophagus, and from there the blood drains through the asparagus vein into the superior vena cava and into the heart. So this tract also starts become dilated. The other points of a photosystemic collateral formation is the behind the posterior part of the body. That is retroperitoneal surfaces where the lumbar veins are which drain into the superior vena cava. The other point being the hemorrhoidal veins, which here also the middle and inferior rectal veins which drain into the systemic veins. This is the inferior mesenteric vein which drains the blood from the rectum. So due to the increased pressure, the blood from the inferior mesenteric vein, which goes through this plexus and drains into the systemic veins via the superior, middle and inferior rectal veins. So this leads to the formation of the uh, hemorrhoids in patients with portal hypertension. And this splenic vein, which drains via the short gastric veins into the stomach. So this pathway also becomes enlarged. So this leads to the splenomegaly as well as the isolated gastric varices which is seen in the fundus. So these are the few common points of a portal hypertension. The clinical impact being the hepatic encephalopathy, hepatopulmonary syndrome, hepatorenal syndrome. All these causes are caused because of the bypass of the venous blood through the portosystemic collaterals without going through the liver. So there is in hepatic encephalopathy, there is a reversible impairment of the neuropsychiatric function. The pathogenesis is unclear, but the probable suspected causes being the increased ammonia, because ammonia combines with the carbon dioxide within the liver, the urea cycle, to form urea, which is excreted through the kidney. Since this venous blood is bypassing the liver, there is decreased clearance of ammonia, which leads to increased serum concentration of ammonia, which directly affects the blood, leading to the hepatic encephalopathy. The other pathways that have been hypothesized are the inhibitory neurotransmitter through the GABA receptors in the central nervous system and the changes in the central neurotransmitters as well as amino acids. Similar, the hepatopulmonary syndrome, in which the patient has a decreased oxygenation. This is because of the intrapulmonary vascular dilatation. These are also the results of liver cirrhosis, where nitric oxide is released in increased amounts, leading to the pulmonary vascular dilatation. So, just like what we see in the liver, the lungs also, the blood is diverted from the liver as in liver. I'm sorry, the intrapulmonary vascular dilatation leads to bypassing the liver, bypassing the lung parenchyma. So so instead of going into the small capillaries, the blood is diverted into the venous system. So there is impaired oxygenation. The oxygenation doesn't occur in the lung properly. So this leads to the decreased oxygen saturation, and many of them might be dependent on oxygen. So this triad of liver disease with impaired oxygenation and intrapulmonary vascular dilatation is called the hepatopulmonary syndrome. Similarly, the hepatorenal syndrome is when the AKA develops due to the diversion of blood from the systemic circulation due to the portal hypertension. It is also seen in fulminant hepatic failure. And the diagnostic criteria for hepatic renal syndrome is basically a diagnosis of exclusion, where you are ruling out all the other conditions like any other infection or hypotension or nephrotoxic drugs. And usually the onset of hepatorenal syndrome portends a poor prognosis to the patient. And coming to the functions of the liver, liver performs a myriad of functions like detoxification, metabolism, taking care of the immunity, protein synthesis, the production of bile, blood sugar balance, storage of micronutrients, and the production of cholesterol. So detoxification is basically the metabolism of most of the drugs that we consume as well as the nutrients occurs in the liver. So drugs, alcohol, fatty liver, steroids, hormones, ammonia, like I mentioned before, and the other toxins, whatever which gains access into the blood circulation is being metabolized in the liver, and they are converted into less toxic components which are excreted either through the bile or through the kidneys. Um, as a part of the immune system, as we saw before, the Kupffer cells, which are part of the liver, are macrophages, which takes care of the viruses as well as pathogens that gain access from the portal vein into the liver. And the storage of multiple micronutrients, minerals, vitamins like the fat-soluble vitamins A, D, E, and K, as well as vitamin B12 are stored in liver. And the blood sugar balance, because during the nutritional phase, whatever nutrients that is coming from the blood is being stored into the liver. So the glucose is being stored as glycogen, and the excess glucose will be converted into fat also, which will come into later. The production of bile, as we saw before, the protein synthesis, the multiple proteins which are important for blood clotting, the immune function, albumin, ceruloplasmin, etc., are being synthesized in the liver. So the protein synthesis, the multiple plasma proteins like AFP, fibronectin, C-reactive proteins are which are acute phase reactants and on the presence of infection. Then the opsonin, which takes care of immunity, and globulins are all synthesized in the liver. And the entire coagulation cascade proteins, except factor 8, is being synthesized in the liver. Other proteins which are involved in the blood coagulation, like antithrombin 3, protein C, protein S, plasminogen, are also synthesized in liver. Multiple hormones, prohormones are also being synthesized, as well as metabolized in liver also. The carrier proteins like albumin, ceruloplasmin, transportin, haptoglobulin, sex hormone binding globulin. The impact of this protein synthesis is that when the liver is hit as in like a cirrhotic patients, there is an imbalance of in the synthesis of these proteins. So there will be decreased formation of coagulant proteins, which leads to increased INR values and bleeding. The plasma proteins like albumin and all being synthesized in lesser amount, which leads to third space fluid loss in the form of edema. And the carrier proteins like a sex hormone binding globulin, which leads to a disparity in the level of androgen as well as estrogen, which leads to gynecomastia in cirrhotic patients. Coming to the carbohydrate metabolism, all forms of carbohydrate metabolism, that is the formation of glucose in the form of gluconeogenesis and the lysis of glycogen as well as glycogenesis, everything happens in the liver. Coming to the fat metabolism, the triglycerides which are absorbed from the meal, which is absorbed as fatty acids and glycerol, and they are packaged into the chylomicrons, which is released through the lymphatic system into the blood. And these fatty acids are bound to the hepatocytes when the blood comes to the liver. And this chylomicron, which is formed by the fatty acids as well as um phospholipids, is taken up into the liver and is processed into to form VLDL, the very low density lipoproteins as well as low density lipoproteins. Fatty acids is also being synthesized by the liver by by uh, fa- I'm sorry. The fatty acid is also being synthesized in the liver and it gets converted into triglycerides and are transported into the blood as a very low density lipoproteins. This VLDL is being taken up into the peripheral tissue where it is converted by the lipoprotein lipase to form LDL as well as free fatty acids, which are used locally in the peripheral tissues. The remaining VLDL becomes the low density lipoproteins and are absorbed by the LDL receptors. So the liver also controls the serum cholesterol concentration by removing these LDLs from the circulation. High density lipoproteins are the lipoproteins which carry cholesterol from the peripheries back into the liver to be broken down and is excreted. And it is also, this cholesterol is also being used for synthesis of multiple hormones as well as bile. Coming to the biochemical parameters, the liver function test is better called as a liver biochemical function because what we are measuring by the enzymes that what we see in blood, it doesn't portend the entire liver function, but a part of the liver function only. So in hepatocellular injury, you can see that the serum levels of aminotransferases increase. These are enzymes which are located within the hepatocytes. So the enzymes being the ALT or AST, also called as SGOT, SGPT. These are enzymes. These are hepatocyte enzymes which are located within the cytosol as well as the mitochondria. So whenever there is an injury to the hepatocytes, the membranes of the hepatocytes become permeable, leaking these enzymes into the blood. There is no per se function of these enzymes in the blood, but the level increases due to injury to this liver cells. And the degree of elevation does not correlate with the extent of injury in the liver. That more or less correlates with the etiology of the liver injury. Similarly, other enzymes like alkaline phosphatase and gamma glutamyl transferase are also elevated in the blood when there is a obstruction or there is a damage to the intrahepatic bile ducts. Coming to the aminotransferases, the aspartate transaminase or the serum glutamate oxaloacetate transferase is also found in muscle, kidney, and brain. So the impact being that the AST elevation does not necessarily represent only the liver injury. It can be elevated in cases where there is a muscle injury or a pathologies in the kidney or brain. Similarly, ALT is also seen in multiple other tissues, but in much lesser concentration. The highest concentration of ALT or alanine transaminase is seen in the liver. Hence, it is more specific to the liver injury. So, severe acute elevation of this transaminases or aminotransferases are seen in conditions like viral hepatitis, drug-induced liver injury, or ischemic hepatitis, autoimmune hepatitis, etc. The ratio of these enzymes are also significant because the AST is less specific to the liver and ALT is more specific to the liver. So when the AST is significantly higher than ALT or the AST-ALT ratio when it is more than 2, it is suggestive of alcoholic liver disease. This is because the ALT synthesis is compromised in this condition due to alcoholism, due to the deficiency of vitamin 6. Similarly, the increased AST and ALT is noted in muscle disorders, as I mentioned before, because these enzymes are also found in muscle. But usually, this level of increase will be less than 300, and the ratio will be maintained in 1:1 ratio. And this can be confirmed by checking the serum creatine phosphokinase as well as the aldolase. AST by ALT ratio is less than 1 in patients with a chronic viral hepatitis like hepatitis B or the hepatitis C, and also in conditions of NAFLD. But this ratio increases to more than 1 when these patients develop cirrhosis. Similarly, there are multiple other drugs like NSAIDs, some antibiotics, statins, anti-tuberculosis drugs, and anti-epileptic drugs, which leads to increase in the level of this aminotransferases in blood. Alkaline phosphatase is an enzyme which is located in the canalicular membrane of the hepatocyte. Their exact function is not yet identified, but they are clinically significant because the increase in the level of ALP will suggest a injury to the intrahepatic bile duct or even the extrahepatic bile duct when conditions like a choledocholithiasis, ALP will be elevated. So, but the problem is that the ALP isoenzymes are also noted in bone, small intestine, placenta, and kidney. So in any pathology where there is pathologies that develops in the bone or small intestine, ALP can be elevated. So, and also physiological variations are also noted in patients with the blood group O and B. The intestinal isoenzyme of the ALP is elevated after a fatty meal. The clinical significance is that it is better to check the LFT when the patient is fasting because in patients with these blood groups, those ALP level will be normally elevated if they come after a fatty meal. Similarly, the adolescents have a higher ALP level because which is majority constituted by the bone ALP due to the bone growth occurring in that adolescent period. And also unknown increase in is noted in healthy women after the age of 30, more than men. So in these conditions where there is a doubt whether the ALP is elevated due to a liver injury or the small bowel or bone injury, we can always counter check it with the gamma glutamyl transferase and the 5 nucleotidase enzymes, which are also similar enzymes which are found within the liver. So if these are also elevated, it is primarily liver pathology. When the ALP alone is elevated and GGG and 5' nucleotide is normal, it can be bone ALP. Coming to the metabolism of drugs within the liver, most of the drugs are metabolized in the smooth endoplasmic reticulum within the liver due to the multiple metabolic enzymes like a cytochrome P450 superfamily. So there are two phases of metabolic reactions. The phase one, where there is oxidation or reduction or hydrolysis through multiple enzymes, and the phase two, where this phase one end products are being detoxified. So these are basically conjugation reactions where the metabolite from the phase one is conjugated with methyl groups, sulfonyl groups, acetyl groups, or glucuronide groups and glutathione, so that they are water soluble and can be excreted through the kidney or through the bile. So the clinical impact of this liver metabolism is in that of paracetamol toxicity or acetaminophen metabolism. So normal paracetamol, it is the phase one reaction occurs, and from there, the second part, the glucuronidation or the sulfation occurs, which occupies the majority of the metabolite. So which are non-toxic compounds which are excreted through the kidney. Whereas only 5 to 15% of the paracetamol is converted into N-acetyl parabenzaquinone, which is a toxic component. So since it is only 5%, which is manageable amount, it is combined with the glutathione, which is formed from the N-acetylcysteine, and it forms into cysteine and mercaptopurate conjugates, which are excreted through urine. However, in acetaminophen toxicity, the phase two metabolism, that is the glucuronidation and the sulfation becomes compromised. They become saturated. So, since this pathway is stuck, more and more paracetamol starts to be metabolized through the toxic pathway where it is converted to NAPQI. So, initially, it will be conjugated with the glutathione and excreted. But once the glutathione store, the physiological reserve is compromised, more and more amounts of NAPQI, the toxic component, increases in the blood, and this toxic component injures the hepatocytes. So, as the glutathione becomes depleted, the toxic form damages the hepatocyte cell membranes and lead to acute hepatic necrosis. And this is made worse by concomitant alcohol use or anti-epileptics or a large amount of caffeine, which again increases these levels. So in these cases of the paracetamol toxicity, N-acetylcysteine or NAC has a role because it replenishes the body stores of glutathione, and hence it is the treatment for acetaminophen toxicity. So what we basically do is um, increase the glutathione supplement so that the toxic form is converted to the non-toxic cysteine and mercaptopurate conjugates, which is slowly excreted out of the body. Coming to bilirubin metabolism, bilirubin is formed by the breakdown of heme. 80% from the hemoglobin in the senescent RBCs. So basically, they are from the reticuloendothelial cells in the spleen, and 20% from the other hemoproteins like myoglobin and cytochrome enzymes. The heme is converted into the biliverdin via heme oxygenase, which is a rate limiting step, and the biliverdin is reduced into the bilirubin. The heme oxygenase is found in the Kupffer cells of the liver and the reticuloendothelial cells of the spleen as well. The normal half-life of a serum bilirubin is 4 hours. This bilirubin is a water insoluble compound, hence it is bound to albumin to be taken up into the liver. So this albumin binds to bilirubin in a reversible manner using a hydrogen bonds, and except in conditions where there is a prolonged biliary obstruction and prolonged conjugated hyperbilirubinemia. This albumin binds to the bilirubin and is delivered into the liver. But whenever there is a prolonged obstruction of the bile and there is a conjugated hyperbilirubinemia, albumin binds to this bilirubin with the covalent bonds. This results in the formation of a delta bilirubin. So this delta bilirubin, it takes much more time because it is a covalent bond. It does not usually dissociate immediately. So this delta bilirubin is removed from the body when the albumin is destroyed from the body. So the half-life of albumin is around 21 days. So delta bilirubin also will have a half-life of around 14 to 21 days, after which when the albumin is restored, the bilirubin is removed from the body. So in cases where where there is prolonged biliary obstruction, even though the stenting or some procedure is done to relieve the obstruction, the delta bilirubin will take much longer time. That is why whenever the patients with the obstruction are stented, the bilirubin levels, the initial part will reverse, will come down fast, but the later part where the delta bilirubin is being in the blood, it comes down very slowly. The albumin bilirubin complex dissociates in the liver sinusoids, where the bilirubin is taken up into the hepatocytes. And this is via facilitated diffusion, which is bidirectional. And the defects in these transporters can cause the hyperbilirubinemia, commonly seen in Gilbert syndrome or Crigler-Najjar syndrome. The unconjugated hyperbilirubinemia also results from cirrhosis when the bilirubin produced from the spleen bypasses the liver due to the portosystemic collaterals. So the uptake into the liver is compromised. This leads to the persistent high levels of bilirubin in this in this cirrhotic patients. Once it is within the hepatocytes, the unconjugated bilirubin is retained into the inside the cytoplasm by binding to a number of proteins like a glutathione S transferase superfamily. So later, this bilirubin is converted into uridine. This conjugation happens with a glucuronide component through uridine diphosphate glucuronide transferase. So this is another family of enzymes which converts the bilirubin into mono or diglucuronide conjugates, which is water soluble. So the UGT1A1 is the main enzyme for conjugation, which is deficient in patients with the Gilbert syndrome and the Crigler-Najjar syndromes. The bilirubin conjugation, bilirubin is poorly water soluble because of the hydrogen bond, which makes it toxic and prevents its elimination. The glucuronic acid conjugation of bilirubin makes it water soluble and is excreted into the bile. The conjugated bilirubin excretion from hepatocyte into the bile canaliculi is the only energy dependent step in this metabolism. Rest all the pathways are all free of energy. This is why even in the acute liver failure patients, the conjugated bilirubin will be of a higher level than the unconjugated bilirubin. Now, coming to the excretion, the conjugated bilirubin is excreted into the bile across the canalicular membrane of the hepatocytes via active transport, as we mentioned before. There are multiple transporter proteins involved in this. So, excretion is impaired in cases of viral hepatitis, or there is a cholestasis of a pregnancy, or Dibbin-Johnson and Rotor syndrome. So, these are the conditions where there is a enzymatic deficiency or a deficiency of these transporter proteins. This leads to increased levels of a conjugated bilirubin. And coming to bilirubin degradation, once the bilirubin is secreted into the bile, 98% of the bile pigment is conjugated and is water soluble. So this water soluble bile will not be absorbed across the lipid membrane of the small intestine epithelium. This bilirubin but is hydrolyzed by the bacterial enzyme beta glucuronidase in the colon, and it is then reduced into the urobilinogen and stercobilinogen. This stercobilinogen is secreted in the stools, and it is what gives the yellow color to the stools. Urobilinogen is reabsorbed into circulation and again to be secreted into the bile. The unconjugated fraction is partially reabsorbed to the enterohepatic circulation because now it is a fat soluble. So the level of intestinal microflora influence the serum bilirubin levels, and the antibiotic use, which can deplete this microflora, can also alter the levels of serum bilirubin. So from the RBCs or the senescent RBCs, the hemoglobin is digested into heme, then into the biliverdin, and then bilirubin, which is water insoluble. So this bilirubin is combined with albumin and transported to the liver. Here it is taken up inside the hepatocyte and it is conjugated with the glucuronide and it is excreted into the intestine. From the intestine, the beta glucuronidase of the bacteria acts on it to form the urobilinogen and stercobilinogen. The stercobilinogen is excreted and urobilinogen is reabsorbed into the blood because it is a fat soluble. Now, coming to the bilirubin measurement, in the initial phase during the identification of the bilirubin, there were many attempts to measure the level of bilirubin. So Vandenberg was the scientist who initially came up with the methods to measure the bilirubin. So hence that reaction is also known in his name. So in this Vandenberg reaction, the bilirubin is in the serum or the blood is mixed with the diazotized sulfonilic acid. So the conjugated or the water soluble bilirubin is readily reacting with this diazotized sulfonilic acid and it can be measured. So this is why it is called a direct. So the direct component of the bilirubin is the part that is conjugated bilirubin or the bilirubin with the glucuronic acid. Because it can be measured immediately without addition of any other substance. Whereas the unconjugated bilirubin, it cannot be measured because it is not water soluble. And to make it water soluble, we add an accelerant called alcohol or caffeine to dissolve the unconjugated bilirubin. So after this, it takes around more time, around 1 hour it takes. And the level of bilirubin what we measure then is the total bilirubin. That is the sum of the conjugated as well as the unconjugated bilirubin. So the indirect bilirubin is calculated by reducing the amount of conjugated bilirubin which was measured initially from the total bilirubin. There are newer methods like a high performance liquid chromatography, which is available, but there is no added advantage and it's much more costlier to conduct the bilirubin measurement through HPLC. So usually the direct fraction or the conjugated bilirubin is less than 50 percentage. It is considered normal. If it is more than 15 percentage, then we have to suspect liver injury. But based on the level of or the fraction of the conjugated or unconjugated bilirubin, we cannot differentiate into hepatocellular or obstructive jaundice, as it is usually taught in schools, medical schools. Like we tell that if when there is obstruction, though already the conjugated bilirubin is regurgitated into the blood, so the direct component will be higher. Whereas in hepatocellular jaundice, or when there is an inflammation within the hepatocytes, the conjugation process is compromised. This leads to the increase in the unconjugated bilirubin, but that is not the case. Uh, the only thing what we can infer is that whenever the direct fraction is more than 15 percentage, there is a liver injury. So we have to evaluate the nature of the liver injury based on other factors like the AST, ALT, or even the ALP levels. So based on those only we can differentiate whether they are hepatocellular or obstructive jaundice. The clinical impact being the hyperbilirubinemia can be due to overproduction in conditions like a hemolysis or due to impaired uptake of a bilirubin or impaired conjugation or impaired excretion into the blood or regurgitation of the conjugated bilirubin from the damaged hepatocytes. And these are the multiple causes that can lead to jaundice. And conjunctival icterus, what we usually see when we are examining a patient, occurs when the serum bilirubin level crosses more than 3 milligram per deciliter. The high colored urine is due to the conjugated bilirubin because unconjugated bilirubin is not water soluble and it cannot move across the glomeruli in the kidney. So only the conjugated bilirubin, which is a glucuronide component, which is water soluble, can move across the kidney and can be excreted in the urine. So whenever the patient is having a high colored urine, that means the patient is having a conjugated hyperbilirubinemia, or in other words, patient is having an obstructive jaundice. When the if the less than 50 percentage is conjugated, or you can consider that the whole serum bilirubin is virtually unconjugated. So in such conditions, the unconjugated hyperbilirubinemia is occurring. So that means the conditions which are told initially, like overproduction due to hemolysis or impaired uptake, like impaired uptake, conjugation, and excretion due to multiple conditions like drug-induced or genetic enzyme deficiency, like Gilbert syndrome, Crigler-Najjar syndrome can be the etiology. So I think that's it. Thank you.
Thank you so much, sir. I think there was a very detailed presentation. So I remember, like, I think the last time we learned about our anatomy and physiology was in our family first year. So we have a whole subject on anatomy and physiology, and most of the time we just go through few topics just for the sake of the exam, and then we just skip major of the topics. But then when we get into a specialty department, we realize the importance of actually knowing the basics of it all. We can actually treat anything without knowing the basics after all. So thank you so much for that detailed presentation. Just two questions questions I had. So now you just mentioned about the hyperbilirubinemia. So I think
Yes.
most of the patients, like we have seen most of the patients coming into the OP and they see this indirect like raised bilirubin level. So their concern is the raised bilirubin levels. They don't look at whether it is a direct bilirubin or indirect bilirubin. So we try to explain that it's not like a major of concern, but actually, is it something to be concerned of, the indirect hyperbilirubinemia, and is there a treatment for it? How do we go about it, about the indirect hyperbilirubinemia?
So basically, we do not treat the lab value. So we have to see the patient. So what is the etiology? Hyper direct or indirect hyperbilirubinemia, whatever it is, you have to identify the etiology. So just having a high bilirubin, we have to see the other component of the liver function test. That is the aminotransferase, whether SGOT, SGPT is elevated, alkaline phosphatase is increased. So in a patient when they have high bilirubin and a high AST or high ALT, as well as high alkaline phosphatase, it is more likely to be an obstructive jaundice because the bilirubin is elevated, and most of the time it will be like conjugated bilirubin. And along with that, the AST and ALT is increased. That is because of this obstruction, there is a partial injury and there is a increased permeability of the hepatocytes. This leads to leakage of the AST and the ALT into the blood. And similarly, the alkaline phosphatase, which is located in the biliary canaliculi, the bile duct, and that also is increased. That is because there is an obstruction. Whereas if you look into the case like there is an hemolysis or some other condition which is causing more of a this unconjugated bilirubin. So in those conditions, when you see that the AST or ALT or alphos will be usually normal. So this is how you'll be able to differentiate. So you have to primarily identify what is the etiology that led to the jaundice. It can be either an obstructive or a surgical jaundice, or a conditions like a overproduction. There is a hemolysis or a hepatocellular jaundice, like a hepatitis or a drug-induced liver injury. So based on this battery of lab reports, you identify the etiology and you treat the etiology. There is no point in just treating the level.
Okay. Okay, sir. And also about the GGT. So most often we tend to correlate GGT with alcohol toxicity or alcoholic liver
Yes.
injury. So is it actually true? Is it the only time when GGT goes up, or?
Yeah, actually, there are some studies which show that the GGT is elevated in case of alcohol. But even in the medical gastro book, like for this preparation, I had used the Schlesinger and Fortin, the medical gastro book only. In there also, it is clearly mentioned that the GGT is elevated in alcohol, but it is not very specific. So you can't
Okay.
tell that just because GGT is elevated, it is alcohol. But almost 50 to 60% of the time, it might be right, but the remaining 40% it may not be right. So
Okay.
solely based on the elevated GGT level, you can tell that it's an alcoholic. But more than that, what you can use is like a AST by ALT ratio. Like I explained in
Okay.
that slides. So if that
Hmm.
ratio is more than 2, that is more suggestive of an alcohol liver injury. And if it is more than 3, it is very specific. The
Yeah.
sensitivity and specificity increases when the AST ALT ratio is higher. And
Okay.
you can also, if in such a patient, when this ratio is more than 2 and the GGT is also elevated, you can be sure that it is due to alcohol. But only when
Okay.
the GGT is alone is elevated and AST-ALT ratio is like less than 2, you can't be sure.
Okay. Okay. So I think thank you so much, sir. I think it was like quite detailed presentation. Like I can't
I,
stop
I,
saying
I feel like
about.
it might be a little bit confusing because even I had to go through the biochemistry classes again, this unconjugated and conjugate, because mostly
Yeah.
we will be dealing with the direct and indirect. So that's why I
Mm.
tried to explain that last slide, what is direct and what is indirect and how that
Mm.
correlates with the level of liver injury. So
Yeah.
you might have to go through this few more times to get your concept around it because it was difficult for me as well.
Yeah.
Even though
No,
we
it's
are using
actually,
the term left and right, you have to
yeah.
understand like why it is direct and why it is indirect and which conditions it increases.
Yeah, because it's quite common as well. Because we have seen a lot of patients, after transplantation, they come and they present with this indirect hyperbilirubinemia. So it's like quite common, and it's very important that we need to know about it as well. So we have quite clearly, actually, you have mentioned it, at least something that we can actually understand. So thank you so much, sir, for taking your valuable time and taking the time to explain all this in detail. So on behalf of FCPI, I would like to extend a warm thank you, and thank you so much for your time, sir. Thank you.
Yeah.